Today's lecture will cover radiation dosimetry in CT, some basic dose concepts. The technologist must understand the benefit versus the risk of any procedure and attempt to maximize the benefits and minimize the risk. Two components for patient care in CT are appropriate patient selection and the minimization of dose without compromising image quality. The ACR created guidelines to assist with appropriate patient selection. Strategies to minimize dose include measurement terminology. The ionizing radiation energy for CT is about 120 to 140 keV. The unit of X-ray exposure in air is the Röntgen. Unit of absorbed dose is the rad, that is the energy absorbed per unit mass. The International System of Units, the unit of absorbed dose is the gray. 100 rad equals 1 gray, or 1 centigrade equals 1 rad. Other factors to consider are the quality factor, which is applied to absorbed dose and accounts for the different biological effects produced from different types of ionizing radiation. Q equals 1 for diagnostic X-rays used in CT. Dose equivalent is the absorbed dose with the application of a quality factor. It's measured in rem, which is Röntgen equivalent man, or sievert for the SI unit. 100 rem equals 1 sievert. Equivalent dose, also known as H, is the product of the absorbed dose and the radiation weighting factor, also measured in rem or sieverts. The effective dose accounts for the effects to a particular tissue with a weighted average of the organ doses, and the weighting factors are set by the ICRP. With film screen imaging, the entrance skin receives 100% of exposure and then it drops off with attenuation throughout the body or throughout the part. When the beam exits, most of the radiation is absorbed or scattered. The difference between entrance and exit exposures is not as great in CT. Dose is more uniform due to heavily filtered the beam and exposure comes from all directions. The uniformity of the dose decreases as the scan field of view and patient thickness increases. Body scans are less uniform than the head. There are variations within the scan plane and along the length of the patient's z-axis, or long axis, described as the z-axis dose distribution. The radiation that scatters to the adjacent slices, also known as tails, is added to the dose of each slice. The amount of scatter that contributes to dose depends on patient size, physical makeup, and the amount of KVP that was used. Tails contribute approximately 25 to 40% of additional dose to the entire study. The total dose equals the central slice dose plus the scatter overlap, also known as the multiple scan average dose, and it will increase if slices overlap. Computed tomography dose index, also known as the CTDI, is an estimate of the MSAD to be accomplished with a single scan. It is a measurement of exposure per slice. This measurement is reported to the U.S. Food and Drug Administration to show doses typically delivered by machines. It can only be calculated if slices are contiguous, which means they have no overlap or gap. The CTDI is multiplied by a ratio of slice thickness to slice increment if it overlaps or gaps. A pencil ionization chamber measures the CTDI. For body scans, the dose is not uniform. The CTDI adjusts with a weighted average of measurements at the center and at the periphery. If the length of the scan is accounted for, dose length product is used, and dose length product is the CTDI times the scan length. CT is an excellent low contrast discriminator because of highly collimated beam and a low amount of scatter that reaches the detector. Film is unable to discriminate objects with less than 10% of contrast in the background. CT can display small differences in density, which allows for soft tissue visualization. An adequate number of photons per pixel, which is calculated by dose, must be gathered to reduce noise. Radiation dose for CT is substantially higher than film screen imaging. Doses vary by the type and the manufacturer of the scanner. Some of the factors that affect dose: the radiation beam geometry. Scanners that use 360-degree rotation create more dose than a 180-degree rotation because it causes overscanning. Filtration removes low-energy rays and reduces dose while maintaining contrast. And detector efficiency Less efficient detectors require more exposure to produce adequate images. Slice width and spacing. As slice thickness increases, the volume of tissue increases. Decreasing the slice thickness and using contiguous slices will increase dose due to scatter. Thinner slices require higher dose, and collimators must be opened slightly for multi-detector scanners. Pitch is the spacing of slices obtained with a spiral helical scan process. This is the distance the table travels in one 360-degree rotation divided by collimated width of the beam. A pitch of 1 means that slices are adjacent with no overlap. Increasing the pitch will spread radiation more thinly over the slices. Scan field diameter means that smaller objects absorb more dose by a factor of 2. The radiographic technique, the higher the mass in kVp, the higher the patient dose. Mass has a direct relationship with dose. If one increases, the other increases. An increase in kVp also increases dose, but not proportionally. Patient size or part thickness. Larger parts require more dose to reduce noise. Repeat scans require additional dose for repeats, and the dose is cumulative. Collimation. If the beam is larger than the detector size, additional scatter is created, so there's more dose involved. And localization scans. These are scout images that are low dose. CT dose contributes greatly to overall radiation dose from all radiologic sources. 11% of diagnostic procedures performed are CT. 67% of effective dose due to CT dose being higher than general radiography. One abdomen CT equals about 100 to 250 chest x-rays. Faster scanners have reduced the need for sedation in pediatrics, but dose is 27 to 305% higher with multi-detector scanners versus single slice scanners. The reason for this is because more CT studies are being performed, and there are higher doses associated with newer scanners. Research findings have shown that effective doses for CT are similar to Japanese survivors of the atomic bomb. The survivors show an increased risk of cancer due to radiation exposure. Radiation doses from typical CT studies may cause cancer-related death in 1 in 1,000 children examined. Everyone in healthcare needs to be educated, especially in the care for children. Parents, pediatricians, technologists, and radiologists lack basic information about the dose obtained during the CT scans. Technical parameters that can be adjusted to lower dose are the MA and the pitch. Many children are imaged using parameters that are set for adult patients, and this results in unnecessary radiation. The dose is about 50% higher if using adult parameters on children. Approximately 20 to 25% of radiologists did not know parameters were used. There is a need for size and age-based scanning. Extra images are obtained beyond the specific area of interest. Dose is directly proportional to the scan volume when all other parameters are held constant. Restriction of scanning to the area of interest will reduce dose and will not affect diagnosis. Typically, extra images hold no additional diagnostic value. Studies have shown a lack of awareness of the dose and possible risks of CT for patients, emergency physicians, and radiologists. It is the responsibility of the technologist to educate the patient on the risk, but only 7% of those patients surveyed had been educated. The results of the studies indicate that patients are not informed about the risks, benefits, and doses for CT scans. Risks associated with CT are linked to higher use, new scanners with higher doses, new information correlating the effects of low-dose radiation to a higher lifetime risk, lack of knowledge about dose, and studies showing that no adjustment in technique for various patient ages and sizes. There's a small, significant increase in cancer deaths over the lifetime of individuals having CT scans in childhood. Scientists define risk according to the nature of harm that could occur, the probability that will occur, and the number of people that it will affect. The general public does not factor in the probability and the size of the risk. Some of the factors that affect public perception include catastrophic potential, which means people are concerned with things that kill many at once rather than those that are random. Familiarity, They are more concerned about familiar risks such as the ozone. Understanding, they are more concerned about less understood activities. Scientific uncertainty, they are more concerned about risks that are scientifically unknown or uncertain. Controllability, they are more concerned about risk not under personal control. Voluntariness of exposure, they are more concerned about risks that are imposed. The impact on children, they are more concerned about risks that disproportionately affect children. The three general principles of risk for pediatric patients include the patient. The parent or patient should be informed of the risk. The procedure should only be performed when indicated and allows a diagnostic benefit that is difficult to obtain any other way. And every effort should be made to decrease dose by adjusting kVp and mass to the size of the patient. There are three primary factors that are special considerations for pediatrics. It increases sensitivity. Children are more radiosensitive because they have more time to develop cancer. The exposure is cumulative, and children are 4 to 6 times more sensitive to the effects. The higher the effective dose, even with adjusted parameters, dose is still larger in a child, and increasing use. Helical scanners offer faster solutions, and they're ordered more often. Exposure to the ionizing radiation while in the uterus can be harmful to the fetus. The developing fetus is most radiosensitive from conception to 3 months due to organ and neural chest development. Estimations of childhood cancer due to fetal exposure are 2 in 600. Doses are lower for protocols that do not deliver dose directly to the area of the fetus, such as the head or the chest. Risk versus benefit must be carefully weighted. Some strategies for reducing dose. Adjust the MA. Mass must be adjusted according to patient size. Automatic tube current modulation. The machine makes changes in MA based upon estimated attenuation of patient. Avoid increasing the kVp because this increases the dose and the penetration power of the beam. It can increase kVp and reduce MA. Increased pitch, change from 1 to 1.5 to decrease dose without decreasing quality. Limit use of thin slices. This results in 30 to 50% more dose. Limit repeat scans. This affects the repeats are cumulative. And newer reconstruction methods can reduce dose by approximately 50%. Some strategies for dose reduction in pediatric patients include only use CT when clinically indicated, use other modalities such as ultrasound or MRI if the same information can be acquired. Customize the exam, which means limit the region of interest and limit the use of multi-phase imaging. The technical parameters should be adjusted for the size and age of the patient. Adjust the mass for patient size and the region scanned, and patient shielding not to cover the area of interest. In summary, CT is a valuable tool for diagnosis. CT does involve risk due to radiation exposure, but the benefit of the exam should outweigh the risk. There are many strategies that can be utilized to reduce dose to the pediatric and adult patients.